panellists. So we have Julie and Kirsten in our region to have a conversation about behavioural interventions in the pandemic. So what we're going to do now is get Julie and Kirsten to talk to about 5 to 7 minutes, reflecting on John's comments and what it might be like and what they think about that and what we've done in this region in terms of behavioural interventions. And then we're going to move to some questions from the audience. So just a reminder, put them up in the chat and we will direct them. If you feel like you want to ask individual people, let them know and we'll direct those that way. So let's start with you, Julie. You have some reflections on what John's been talking about.
Mute.
Sorry, Zoom, don't you love it? So yeah, hi everyone, I'm on Darug country and I'd like to acknowledge the traditional owners and elders past, present and future. So I actually really struggled with not making this a great big whinge fest because Australia did not do well in using its existing behavioural science expertise. And there's a lot we can learn and I hope government is able to reflect on for future. But essentially we have a strong behavioural science capacity in Australia. But, and we have, for example, with vaccination, the collaboration on social science and immunisation, which we started some years ago, which I note that Holly, the Deputy Chair, has joined us today. And yet government did not use us at the beginning of the pandemic when we knew we had a lot to offer. And what I think happened, and I promise this won't be a whinge fest, but I do want to sort of name what was happening in 2020, which is that the government tended to see the public health response as a medical one and then an epidemiological one, which I know that the discussants from the UK version of this webinar commented on as well, without a recognition that there's a science to behaviour change and sustaining, and there's a science to good communication. So that we had a government that relied very heavily on market researchers, consultancy companies, and millions and millions and millions of dollars went into those companies. And the advantage for government there is that they can quickly, they have a surge capacity, right? So they can very rapidly do what the government needs done without having to get ethical approval, without those big delays that can mean that the issue has passed by the time you've collected the data. So that's a genuine problem that we need to sort of figure out how we deal with. But in the last pandemic in 2009, this was an issue for lab-based researchers, for modelers, for epidemiologists, and they dealt with that in the preparation for this pandemic. So they'd be able to acquire data quickly, get rapid ethics approval. So I've got to hope that next time we'll be more ready and we'll have helped the government organise more around being ready. We did not have any behavioural science expertise on AHPPC, even though what did happen was there would be fairly regular informal advice sought from people like me through informal back channels from people who were in key decision-making roles. So I think that's an advantage of having that kind of corporate memory. And we definitely have that long-standing expertise in Australia through several people, certainly in immunisation and certainly in risk communication, for example, and health literacy that Kirsten's group has that she can talk to. We did get a little bit of funding here at Sydney University for what I chose to do with that funding was to do an omnibus qualitative study. So we had ethics approval, which took weeks and weeks. But once we had it, we were able to do in-depth interviews with people around the issue of the day because we knew it would change very rapidly from our experience. And so we were able to look at how people perceive pandemic risk and managed it within their households, for example. or why they weren't going for a PCR test if they had symptoms. And we put together rapid sort of reports of the early findings for chief health officers, and that was unsolicited by them. We just did it and put it out there. What ended up happening for me and my colleagues in immunisation in particular is that we ended up doing a lot, because we weren't able to really work in the tent with government, even though we really wanted to support government. And we thought we could do a great job if we had extra funding. I certainly saw that there was huge capacity to make an impact with our knowledge that the public had invested in through a lot of media and public engagement. So I ended up focusing quite a lot on that, and ironically not doing a huge amount of research that I actually led, even though I was involved in behavioural research and advising a lot of people and setting up tools for WHO to help countries understand the behavioural and social drivers of COVID-19 vaccination. So the media engagement for me was quite meaningful, because it meant that we were able to at least see our knowledge have an impact on the public through the sense making and the commentary, and also for advocacy and calls for what was needed. So, for example, with the need for, and this is a little bit off behavioural science, but it's a trust building activity that we didn't have compensation for people who had been injured by a vaccine. And with AstraZeneca vaccine, that became something that we all had to stare at and confront. And fortunately, after years of advocacy, the government brought in no-fault vaccine injury compensation, because we took the opportunity to engage in our advocacy role as social scientists. By 2021, a few of us were on sort of various government advisory committees, again, being able to bring in that long-standing knowledge to inform what was being done now. And that was a positive thing. And we were also able to be a connection between someone who needed some help on something like how you communicate probability when you're looking at vaccine risk and benefit, and the science of that. So, for example, I was able to link up Carissa Bonner, who works with Kirsten, with people in Atagi who were putting together this kind of information, so that we were able to at least try to influence best practice, even though that didn't necessarily always happen. And this year, things have sort of turned a corner, because I think we've realised we need to be, I certainly need to be much more on the front foot with offering expertise and leaning in. And so when we saw that there was a plateauing in childhood vaccination coverage, we ended up putting together a forum to hear from social researchers who are doing research with parents right now, bring that knowledge to government, who were just collecting a sentiment monitoring survey with 150 parents, and bring that extra knowledge that was being acquired elsewhere, and bring community members together where there were already inequities in uptake for children and government, and run just a 2-hour forum. And that inspired a similar forum, that national one with New South Wales conducted one recently. And there's other forums being planned, including one organised by NHMRC between the South African government and the Australian government, bringing in behavioural scientists. So I think, just going back to the global work, I think the most, the highest impact work that we were able to do was not so much in the radar shadow of Australia, but overseas with our work with WHO. I'm chair of the Behavioural and Social Drivers of Vaccination Working Group. We've been working for 3 years, initially on surveys and interview guides to assess the things that influence vaccine uptake in children. And we rapidly adapted those tools to adult vaccination. And so countries around the world had already been able to use the COVID vaccine survey in helping plan their vaccine rollout and see where there were weaknesses in their own system and in areas where they needed to strengthen confidence, access, you name it. And that was through measuring the full range of drivers, not just the attitudinal drivers, not just looking at hesitancy, albeit that being quite an important issue in the rollout. And so for future, I think for me, I have a vision, which is to see the next pandemic have a behavioural scientist on AHPPC, that key decision-making response advice group, and to also see a permanent behavioural scientist embedded within a TARGI, so that that is also informing the decision-making, because it does anyway. They seek that advice informally, and they were doing that more formally during the pandemic, but that structure has been changed. And also we have, I certainly hope that there's going to be a very strong evaluation of how Australia has responded to the pandemic, that each of the states and territories would do that, but also the federal government would do that, not necessarily through a Royal Commission. There are other structures that work very well, such as WHO after-action review or intra-action review structures. And that evaluation would look very carefully at comms and at behavioural insights, and avoid the trap of just thinking about human behaviour as a comms problem, and see it more broadly, so that we're able to really make an impact on how we prepare for the next pandemic and continue to manage infectious diseases. So that's all from me. Thanks very much.
Thank you, Julie. Paul's posted a question. I'm going to leave that for a second and come back to that in a minute. And I've got some follow-up questions that I'm quite keen to post as well. Kirsten, let's move to you. Julie has spoken about your health literacy expertise. You too have done work in this space. Julie has done a lot of work in media and in publications, and I really like the phrase that you wrote about offering expertise and leaning in, which I want to touch back on a bit later. Kirsten, what has it been like for you and your lab and your research, and how has this impacted your work, and what are your reflections on John's talk?
Yeah, thanks, Rain. Thanks, everyone, for coming. And also, I'd like to acknowledge the traditional owners of this land. I'm on Gadigal land. So look, I lead a team of behavioural scientists working in health literacy and behaviour change in lots of different areas, and but not in pandemic management and not in infectious disease typically. But when we saw the communications in the early phase of the pandemic, we sort of threw our hands up in despair, really, that none of the sort of 30 years of advice about good, clear communication was being followed. Absolutely not one piece of that advice had been taken. So that's what really drove our decision to get involved in some research. And look, we were completely outside of any policy we were not at any policy table. We just got on with some research because we felt it needed to be out there. And we got very little funding. We basically did it on a shoestring. We did it with kind of leftovers of consultancies that hadn't been, funds that hadn't been spent. And we ended up doing a lot. We did 5 public surveys. We did a survey of GPs, national survey of GPs, 2 RCTs, and health literacy analysis of online information. So we did a lot over 2 years. And the total funding that we got for that was $25,000. And that was from a CRE that was led out of Sydney University on infectious disease, led by Tanya Sorrell and Ben Murray. And we were incredibly grateful for that. And it's interesting listening to the speaker, and for people who haven't listened to the discussants afterwards, it's very worthwhile listening to the experience in Ireland and the experience in Netherlands, because it was completely different to Australia. Absolutely, completely different. I think in Netherlands, they were given €1 million to do behavioural science research to feed into the pandemic response. And in Ireland, they were integrated, a team was integrated into the kind of policy decision-making kind of framework, really, although there could have been improvements. So anyway, we got on and did a lot of research. And what we did really to influence policy was use our back channel, so the people that we knew who were at the table. And we also used the media a lot. And thanks to colleagues that we'd worked with in Wiser Healthcare, so Ray Moynihan and others, we had got much more adept at working with the media. So writing conversation articles, reaching out to journalists. And journalists did have a huge appetite for this stuff at the time because they could see it was important too. And also thanks to many colleagues on this call, we were invited to present that research to influential bodies. So we presented it to COSI, we presented it to a prize, these national groups working in infectious disease. And at key times, we were also invited to present the findings. So we did a big survey of culturally and linguistically diverse adults in Western Sydney. That was of 700 adults. Again, we didn't get any funding, but that was supported by a really good partnership and network that we had in Western Sydney. And those findings fed into the pandemic response, the Delta response in New South Wales. So what am I saying here? It is a bit of a whinge that there was so little funding made available. Also that there was very little coordination because we knew there was work going on in WA, in Victoria, at ANU, but no one really knew what everyone else was doing. So there was no coordination and probably lots and lots of duplication. Our networks, research networks, really helped us be able to do that work quickly and in a timely way. And I think the speaker makes a really interesting point about RCTs. And I'd love to talk a bit about that because we were able to do lots of surveys and we did 2 RCTs. That was a much harder task on very little funding. And I still believe, and I'd love to hear other people's opinions on this, I still believe that RCTs play an important role. I still want to know, is this intervention better than that one? And I can't think of a better way to do that than with an RCT, and that you can do that with communication interventions. And you can do it quickly, but it needs ethics systems in place to let you have quick ethics turnaround, or in fact, no ethics. If you've got a kind of blanket approval, there should be ways that you can get a blanket approval to do a kind of range of low risk activities in trials. It needs that in place, and it also needs funding so you can do it quickly. Because what we found in our 2 RCTs, we had to keep redoing them because by the time we got to deliver the intervention was out of date and the whole thing had moved on. So we had to redo it. So that was a challenge. What was the other point I wanted to make? I think also the comments about advice being actionable are important to kind of hear and receive. I think as behavioural scientists and perhaps many academics, we're not very good at giving you clear, actionable advice. We want to focus on the nuance, not necessarily make it, ultra clear. So I think that's some advice well taken. And I think moving forward, I would love to see how we can document the contribution of behavioural science. And I'm very interested in Julie, you talked about this WHO process after action review. It'd be good to hear how that actually works and how we can make sure that the work that behavioural science has been is integrated, and we can show what kind of difference that makes. I think that would be really important. And just finally just thinking about the Netherlands experience, they set up an institute of, I think it was behavioural insights, and also an institute of cultural and social research. And both of those institutes were funded to conduct rapid research to feed into policy. And ultimately, of course, that's what we need. That is absolutely what we need. So I'll finish there, and hopefully I haven't whinged too much.
Thank you both. I think it's really hard because, I mean, we actually, Paul and I do have meetings and we do these webinars, and all of us know we don't want to whinge. And yet there's so much to do, and so much was a missed opportunity. And we've been working on some lessons learned for the World Health Organization. And some of these things that we've been talking about today have come up over and over again. And it's a bit like, well, when are we actually going to learn those lessons and move on? So there's a couple of questions that have been posted into the chat. And I actually think, because we're a relatively small group, we've got 15 minutes, I'd actually like to ask the people who have posted the question, if they're willing, to potentially ask the questions of Kirsten and Julie. So Paul, you've posted the question. It's been partly answered, but not quite. Do you want to talk about the question about the BI body equivalent?
Oh, so I absolutely agree about the needs for behavioural insights representation on key bodies. But I was also wondering, there's a lot of people, there's a lot of insight that's needed from a variety of behavioural disciplines, or BESSI disciplines more broadly, and that something equivalent to the COVID task force or to a TARGI might be warranted, which then has a liaison with that key body. In other words, I don't think it should just be one person on one key body. I think it needs a larger body than that. But I like the Dutch model as well, where there's actually an institute that's tasked with doing this. I'm not sure. They're just a couple of thoughts about it, and I'll be very interested in Julie and Kirsten's thoughts.
Yeah, thanks for the question, Paul. I actually thought, no, you don't want that. You just want behavioural scientists embedded in whether it be in government, within public health departments, so that they build up the technical expertise and can integrate the epidemiological knowledge with behavioural science expertise. Like people like Kerry Wiley have particular expertise in doing that. She's on the call today. But we actually hearing the other discussants in that webinar that you provided the link for, the fellow from, was it Arj? What was his name? It was the guy from Norway.
Oh, Adler Fretheim.
Thank you. He actually painted a picture of something that could be fantastic, where they had weekly meetings with a group who included behavioural science expertise, comms, ethics, all the social sciences, each contributing to policy dilemmas. They weren't within government, but they then took one of their chair, and that person would communicate with government. And so I almost think that would be a really nice model. And imagining what it could be better look like is something that's hard to do, because we came from such a very basic sort of basis for how we managed it. But I will say that, again, one of the things that I think is a benefit of having existing expertise embedded is that you already know what improves vaccine uptake. And that's something that the COSI group did, which was to put together a document in November 2020 to say, here's a 6-point plan for how we can improve vaccine, if we get high COVID vaccine uptake. And we're just going to write this. Holly Seal led the writing of it, and we just put it out there. And, and people may or may not have read it. But I think definitely having people formally embedded, not just comms, but also behavioural science, is essential within government, and then having that capacity within advisory groups as a core function is essential.
Can I just add? Look, I agree. I think it's really important. I do like the idea of a committee or structure which includes a diverse range of social scientists, because lots of people bring different important components to that perspective. One of the things I still don't quite understand was how, because obviously there are behavioural insights teams in government already. So there's the beta team in the PM Cabinet's office, and there are state versions of that. And I still don't quite understand and maybe someone knows on this call, what their role was during the pandemic, or whether because they have such a, I mean, and we've done some work with them, Paul, you've done some work with them on our Wiser Healthcare, that it's very difficult for them to switch and change and be kind of change tack on what they're doing because they're in government. I don't know, because surely they should be doing some kind of role.
They're often collecting data, but it's not shared publicly. So there was a lot of data being collected, but we don't have visibility to that. It informed government internally. The data that was shared publicly was the vaccine sentiment data from quantum research that the federal government contracted to do. But there's a BI team. I think there's someone here from New South Wales Health. There's a BI team in New South Wales Health who are informing their program and tracking sentiment and around vaccination and giving them insights that that are not publicly available. So we don't know, we can't benefit from that information as well.
Can I also comment, please, that this seems to be a theme too. It's like, you know, there's Kirsten mentioned about lack of coordination. You both mentioned about duplication of research. We have ethics that are taking too long. By the time we finished our research, it's moved on. Paul's posted in the chat that recovery had 3 days. The ethics took 3 days for recovery. And we noticed with these big trials, what we've learned is that you can actually share data. And I think John talked about, he said that the pandemic has stimulated data sharing. And I'm not entirely sure that that's our experience, nor is it necessarily a more global experience. But is there anything about these functions that we can do about collecting, about understanding who's doing what? Holly mentioned that there were gaps in the states in behavioural interventions. So how do we collate, collect and share all this information?
I think that speaks to there being some kind of institute. It requires some sort of national entity to do that coordination, and that needs some infrastructure and that needs some funding. And we need to make it very clear that the work that has been done has been uncoordinated and could have been much better done had we had some kind of overarching structure and organisation and communication.
Like a CDC.
I wondered.
A lot of talk about it at the moment.
Yeah.
But COSI was also sharing, we were sharing our resources anyway. We ran more than 150, I'd say, between us webinars to support vaccine advocacy and champion work in communities and professional groups. And we just pooled our resources at the very beginning of the rollout, knowing there was an urgent need, and brought it all together. And, you know, you always live in that lovely tension between collaboration and competition. We just threw competition out the window and just pulled everything.
There's so much expertise online right now. I'm wondering if anybody online wants to put up their hand and ask a question. Yeah, Holly.
Yeah, thank you. And I appreciate the comments that have been made so far, just really picking up on that point about, you know, that kind of body to oversee things or potentially just to bring things together. You know, I think what has been seen, you know, coming out of the H1N1 pandemic and you know, was that kind of bringing together of the modelers. You know, they really are, you know, a group that, you know, were the go-tos for government, and there was, you know, that they got funding. You know, the prize, I think it's a CRE down in Victoria, you know, really, you know, they were driving, you know, studies, and they had the ethics, you know, there in place. But I think the group acknowledged that they had, I not want to say failed to, but perhaps the recognition of the need for social science within that group also, you know, hadn't been recognised early enough, and it was a gap. And I think they acknowledged it was a gap. And so, you know, why, you know, where did we miss in terms of, you know, advocating for the need for social science as part of pandemic planning? I think also falls on our shoulders. And coming out of this, you know, this next pandemic, I think we do need to be you know, stronger in our messaging going out around the need to have, the social scientists next door to the modelers, next door to the epidemiologists, and part of these granting opportunities so that we're ready to go next time round.
Yeah. Can I Holly, that's so true, but I'm just going back to like what happens, and the point that Julie made was the government goes to marketing agencies to do this work, to do it quickly and to do it well, I don't know. I mean, I would say in a low quality, it's low quality, it's quick, and I guess it's short term. It's certainly not cheap, but it's ideologically, it's more favourable to them. And I guess it is also about surge capacity. But it's very frustrating. I think that's one of the things we need to show, is that outsourcing to market researchers doesn't get you doesn't deliver what behavioural science and this kind of social science research and advice could deliver.
Yeah, no, I agree on that point. And I think that was where, I think, you don't want to go around pointing fingers and drawing on issues, but I think we can all attest to the fact that, even though these millions of dollars were given, the research was done, it really didn't quite end up in the results, the media campaigns, the interventions that perhaps were really needed. And certainly in the work you've been doing, I've been doing for culturally and linguistically diverse, there's clear examples that can be used, to say, look, this is where we miss out on drawing on experts. They wouldn't do this for the modelers. And so it is about getting that same recognition that, we have got, people like Julie who bring in, years and years. Well, I wasn't going to say the amount, otherwise Julie might chastise me for either underselling or overselling, but and that is it, and I draw on the modelers because I saw a big change in kind of what happened to them kind of leading into 2009, and then what happened coming out of 2009, and them as a network. Yes, there's a bit of infighting, but certainly they were the first ones to be tapped on the shoulder, given funding, and asked to crunch the numbers.
Mm-hmm.
We have potentially 2 more minutes if anybody else would like to make a comment or a question before we head off. Kerry, you look like you paused to press a button somewhere. You're on mute though. And Ginny would be next. Yeah.
Yeah, I was just saying, I'm living this all over again right now. I've just started helping with the Japanese encephalitis outbreak, and it's the same thing over again, trying to figure out who the people to talk to in government. And I'm not just working with health departments now, I'm working with Department of Primary Industry and industry itself, because we've got the added layer of animals as well as humans. And I actually managed to get an ethics application inside of 24 hours, but there's no avenue for it. And so what we're talking about here is just singing to me. I really think we need to have something set up with avenues in place that we can hit the go button and say, right, and it not necessarily, I'm not talking necessarily pandemic, I'm actually looking at One Health type things like Japanese encephalitis, things where we need behavioural insight, but no one really, even the people I was talking to were saying, yes, we really need you to do this, but again, it's not funded. I'm funding this out of my NH and MRC investigator grant because there's money, but no one knows how to get to it. So yeah, I think what we need is infrastructure. I really think we need not just groups who can sit and I think the idea of having a group that can feed into government is great, but I think we also need the practical infrastructure as well, where we can actually get up and mobilise researchers and resources quickly to respond quickly.
Quickly, do either of you want to comment before I move to Ginny and then potentially Paul? I agree. I'm not sure about anybody else. Okay, I'll move to Ginny. Ginny, you posted on chat about organising sharing. What are your thoughts?
Yeah, so thanks for a great discussion. And I'm definitely not a behavioural scientist. My kind of area is open access and open science. But we have a group that we've set up quite a while ago, which has representatives of NHMRC, some of the government departments, Universities of Australia, where we're trying to use it as a sort of route into government. Now, I'm the first to say that it hasn't moved as quickly as we'd like it to have. But what we have found is that it's been an incredibly important information sharing group that you should never overestimate how much they know about what's going on, because quite often we're sharing stuff with them that we thought was blindingly obvious that they had literally no idea of. And I'm quite confident it did lead us to kind of having some roots in that we wouldn't have had before. But it's a long-term project. So this idea about having a kind of a group that provides advice to government, I'd just set it up and invite them, seriously, and have it in place now. And then obviously you need the bigger infrastructure, and happy to chat more about that. I don't know who those people are, but it's been valuable for us, our particular group, to do that.
Thank you, Ginny. Paul, I'm going to leave it to you. It's 9 o'clock. Your call next.
So a quick comment first on Kerry's was that the Norwegian Institute of Public Health Centre of Atlee Fretheim's not only has the staff within the institute, but their budget actually also allows for funding external researchers as well, which I think is quite an interesting model to have. So you've got both the standing experts, but you can also bring in other people with very quick turnaround funding. And so because it's 9 o'clock, I'm going to finish there, but just to remind people that on the BESSI website, there's a thing listing the future webinars. We're hoping to rebroadcast ones that occur outside convenient hours here. So that will get posted there. And if you want to get a notification of that, there's a JISC mail list, again, that's on the BESSI website that you can sign up for. So thanks everyone for attending. Thanks, Julie and Kirsten, for your excellent discussions. And thanks, Ray, for sharing the end questions. Thanks all. Bye for now.